All right, guys, let's get busy talking about sleep disorders, which are going to be our pathologies that happen usually during sleep time. And let's start out by talking about narcolepsy. Now, I'm highlighting in pink here because narcolepsy to me is very much associated with REM. And if you remember from the previous video, we did all of our REM cycle in our hot pink color. So I want to stay consistent. So, narcolepsy is characterized by people who are pretty normal day to day, and then all of a sudden they are overcome by a very sudden urge to sleep. So this is a rapid onset, profound sleepiness. So I would just be going about my day, texting, typing, and all of a sudden, boom, I am out like a light. All right, that is characteristic of narcolepsy. That's the type of history you're going to hear. Additionally, this is going to be characterized by excessive daytime sleepiness, which makes sense because these people are all of a sudden falling asleep. However, they usually have adequate rest overnight, and this is important to differentiate from insomnia. Whereas patients with insomnia tend not to ever fall asleep during the night, or if they do, it's for very short periods of time, and that's why they are tired during the day. Whereas narcolepsy patients, they sleep throughout the entire night. They just feel sleepy during the day because they have these rapid onset sleeping spells. And let's kind of talk about why these happen. And it's all about the chemical called orexin, also called hypocretin. And this is made in the lateral hypothalamus. And when it is secreted from the lateral hypothalamus, basically it contributes to our wakefulness, to our energy. So you can kind of think of orexin as the opposite of melatonin. So this decrease in orexin is what leads to increased sleepiness and these sleepiness episodes in our patients with narcolepsy. Now remember, this is not going to be the same mechanism as we discussed with sleep physiology, where melatonin is responsible for creating circadian rhythms. This is a completely different mechanism independent to narcolepsy that you need to know for testing. Now, there are some associated symptoms with narcolepsy, one of them being hallucinations, and these hallucinations are actually split into two types, hypnagogic and hypnopompic. Now, for hypnagogic, I'm going to go ahead and highlight this in a dark purple, dark blue color, because these hallucinations happen as patients are falling asleep. And if you look at hypnagogic, it has the word go in it, so it's like go to sleep. So remember, hypnagogic is hallucinations that happen as patients are falling asleep, as opposed to hypnopompic hallucinations, which are going to occur as patients wake up. And I think of yellow as a very much waking up color. So that's why I'm highlighting it this way. Another finding we can see is called cataplexy. And this is going to be the suddening weakening of the lower extremities, classically described as legs turning into jelly. And this is going to happen during intense emotional responses. So really intense laughter or excitement tends to bring on episodes of cataplexy. That's another thing to be looking out for here. Lastly, let's talk about sleep paralysis because this is also associated with narcolepsy. And the reason why sleep paralysis happens is because when narcolepsy patients go right into their sleep episodes, they go directly into REM. Remember, we are highlighting in pink here to make the connection to REM sleep. And remember, we have no motor tone during REM sleep, which is why these patients can sometimes complain of sleep paralysis. Now, let's wrap up by talking a little bit about management. So first off, it's going to be a regular sleep schedule. This is really going to help these patients who struggle with fatigue during the day. They need to have as regular of a sleep schedule as possible. Next, you can use stimulants. The one that we usually use is modafinil, and these are given in the morning because this is when patients should be awake, when they should be at their highest energy. And this is kind of taking place of the orexin that they are not endogenously secreting. Also, when it comes to nighttime, in order for these people to get to sleep, we give them GHB, which is a drug that helps them fall asleep. So this kind of combination of modafinil in the morning and GHB in the night is going to be the key management steps for pharmacologic management of narcolepsy on testing. Let's move on to talk about sleep terror disorder, which I'm going to highlight in purple because it occurs during the N3 stage of sleep. And remember, this is our deepest, kind of most somnolent stage of sleep, where we don't think of a lot of brain activity happening as opposed to like REM sleep, where we think a lot of activity and a lot of brain work is occurring. So in our sleep terror disorder, this is going to be sudden onset terror during sleep, accompanied by screaming without potential for being consoled. And it's really important that we mention that these patients cannot be consoled, because patients with nightmare disorder who have nightmares which occur during REM sleep, they can be consoled. They can be comforted after their nightmare, whereas patients with sleep terror disorder are just going to scream and they're having this intense terror, but they don't remember the dream or the sensation that caused them to have this terror. They just have this unknown kind of really deep subconscious terror that cannot be consoled. Like I said, it occurs during the N3 stage of sleep, and there's no memory of this. And remember, we talked about E being part of N3, and that's because our patients with night terror are screaming E when they have a night terror. So I just want to re-emphasize this is not a nightmare. Nightmares are going to occur during REM sleep, which I'm going to highlight in pink because that's a key differential here. And also patients with our nightmares can be consoled. Our sleep terrors can be precipitated by things like stress, fever, and sleep debt. Now let's actually move on to talking about nightmare disorder, which I'm going to highlight in pink because this occurs during REM sleep. Remember, this is the classically most active brain activity time of sleep. This is different from sleep terror disorder because patients are going to have memories of their nightmares and they're going to be able to be consoled. And this is like the key way you'll be able to differentiate these two on test day. And a follow-up third order question might ask you about the stage of sleep that this occurs in. And for night terrors, it's N3, whereas for nightmares, it's going to be REM. Let's also note that our patients with PTSD are suffering from nightmares and not from night terrors. That's an important differential. Also, our PTSD-induced nightmares can be treated with prazosin, and that mechanism might come up on test day. All right, let's move on to talk about enuresis now, guys. And enuresis is just a fancy word for nighttime bedwetting. And when it comes to step one, we're really going to be looking at our younger patient group here. And there's some important criteria to point out. So in almost all of these questions, our patients must be greater than 5 years old for us to consider treatment. So if you have a patient who's 3 or 4 years old and it's talking about enuresis, most of the time it's just going to be a watch and wait scenario. So we're going to wait for those patients to turn 5 years old before we start considering this a serious pathology. Now, let's say you do have a patient that's greater than 5 years old. It's important that the urinary incontinence is during sleep and greater than 3 times per week for greater than or equal to 3 months. And this is the important diagnostic criteria in terms of timeline. Now, let's talk about how we would manage this if a patient did indeed meet these criteria. So first line is going to be pretty conservative. We're going to just do fluid restriction because, if you drink a lot of water or a lot of fluid before bedtime, you're going to have to go pee. So if we kind of dehydrate these kids before they go to bed, they're going to be less likely to have a full bladder. Also, encouraging kids to use the restroom before going to bed is going to be a great way to empty that bladder as well. Also, positive reinforcement because a lot of these patients tend to have underlying anxiety conditions, so we want to make sure that we're giving them positive reinforcement instead of negative reinforcement. Now, when it comes to refractory causes, we can use things like bedwetting alarms. And a bedwetting alarm is essentially a really fancy pad that is hypersensitive to changes in moisture. So as soon as someone starts wetting the bed, there's basically a little pad that senses that moisture and it's wee-oo, 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 and it basically wakes up the kid and they're like, oh my gosh, I'm wetting the bed. And it's kind of a way for them to say okay, I need to control my bladder. And if they use it over time, it can actually make them have better control over their bladder at nighttime. Also, we can use desmopressin, which is an ADH analog. And remember, ADH is anti-diuretic hormone. So it literally is going to be preventing them from going pee. And you'll remember that ADH works in the collecting duct. That might come up as a third order question, so be on the lookout for that. Now, our third line is going to be imipramine, and this is one of the tricyclic antidepressants, and we like to avoid these at all costs because they have a really nasty side effect profile. There's a lot of anticholinergic, antihistaminic side effects that we won't want to be giving to our young kids. So this is really undesirable, and it's going to be our last ditch effort in cases of enuresis. I also want to make a plug for always screening these patients for a UTI. So that should be another important part of management, because UTIs can cause dysuria, and that may be a reason why a patient is wetting the bed at night. So be sure to always check for an answer choice or something related to bacteriuria or a UTI. So after that, let's move on to talk about our restless leg syndrome. And restless leg syndrome is going to be a bothersome sensation in the legs that's often described as a creepy crawling or electric sensation that is usually only relieved by the urge to move one's leg really fast. So you may have seen someone who taps their leg really frequently, or someone who describes having to fidget a lot at night. That would be someone who is complaining of restless leg syndrome. This is, like I said, almost always going to be worse at night and relieved by movement. And importantly here, I think this is where they can ask things on test day, is it's associated with things like CKD, Parkinson's, and iron deficiency. I would say the biggest one here is definitely Parkinson's physiology. It always tends to be a man who's in his late 50s, early 60s, who has Parkinson's disease and now is presenting with restless leg syndrome. So that's the kind of patient vignette to be looking out for on test day. In terms of our management of this, we're going to use dopamine agonists like ropinirole and pramipexole. So these are going to agonize the dopamine receptor, and this is going to relieve some of those sensations and urges to move. And this makes sense because we know our Parkinson's physiology is all about dopamine and its pathways. So having this diagnosis to be associated with Parkinsonism is a great way for you guys to link this diagnosis, Parkinson's, and its management. Next, let's talk about insomnia. And when it comes to insomnia, I want you guys to be thinking about secondary insults that could be causing insomnia. So usually in step one, we want to elucidate or kind of suss out something else that may be causing insomnia other than primary undifferentiated insomnia. So some things that could cause it are things like stimulants. So stimulants like caffeine, cocaine, nicotine, things that are going to keep people awake are going to also cause insomnia. Also, cannabis is a culprit that sometimes our patients think that cannabis is going to help them sleep, but it can actually keep them awake in some patients. Bupropion is an antidepressant with some activating effects because it inhibits the norepinephrine reuptake system. So we have that additional uplifting norepinephrine in our bloodstream, which can lead to insomnia as well. Also, withdrawal from some of the more downer antidepressants such as trazodone, mirtazapine, and SSRIs can kind of shift the axis of how tired or how awake we feel during the day. Also, hyperthyroidism is going to cause this kind of increase in sympathetic drive, and it's going to make us feel more awake and more alert, especially if these thyroid levels are way above normal. Additionally, patients with shift work tend to have insomnia because they have a lot of difficulty establishing a normal circadian rhythm, like we talked about with the light coming into the retina, with the SCN. Those people do not have a regular schedule, so their circadian rhythm has trouble adapting to that, and it can lead to insomnia. Now, when it comes to management, we want to eliminate that insult. So everything that we just described above are all possibilities you want to be looking for in the history that we can eliminate to help our patient get better sleep. Now, if someone has eliminated seemingly everything and you can't find a culprit and this person still can't get to sleep, there are some pharmacologic options that we can go to. So let's talk about our non-benzodiazepine hypnotics. These start with the letter Z, and the classic one on test day that I always think about is zolpidem. So that's the one to be on the lookout for. There are a few others that you guys may want to memorize, but zolpidem is the one that I always go to. Also, we can use suvorexant, which is actually an antagonist of orexin. And you'll remember when we talked about narcolepsy, we talked about orexin being a chemical that kind of contributes to our feeling of being awake or feeling energetic and alive. And so this medication is an antagonist to that chemical, and it allows us to feel a little more sleepy and allow us to get to sleep a little bit easier. On the other side of the coin, we have Ramelton, and Ramelton is an analog, a pharmacologic analog of melatonin. And you will remember in our first slide on sleep physiology, we talked about how melatonin is released from the pineal gland and it leads to a feeling of sleepiness. So we can kind of give an artificial melatonin called Ramelton, and this helps patients get to sleep who are suffering from insomnia. We can also just use straight up natural over-the-counter melatonin as well here. Lastly, let's talk about some age-related sleep changes that may come up on question stems. I think it's really important here. This is oftentimes going to be with elderly patients, and this is helpful in kind of differentiating patients who may be suffering from major depressive disorder from those who are just having age-related changes. So we expect to see decreased REM sleep and deep sleep in our elderly patients, as well as increased sleep latency. And increased sleep latency just means it is a longer period before they start to fall asleep. So if you and I might fall asleep in 15 to 20 minutes, an old person might take 30 to 35 to fall asleep. Also, older people have increased nighttime awakenings and earlier bedtimes. Additionally, they tend to get up earlier in the morning, and I always remember this because my grandma's always up at 6:30 drinking her coffee, and it's not even trouble for her to get out of bed. And this is just a natural age-related change that we expect, and it can sometimes come up on test day.